So the next portion of our day, as you all begin to feel comfortable in your current seats, we'll focus on evaluating community-based health literacy interventions. First, we will hear from Dr. Andrew Pleasant, whose name was articulated so many times this morning, on the issues and challenges inherent in evaluating these types of interventions. Certainly the challenges will be a focus of attention. Dr. Pleasant is currently the Director of Canyon Ranch Institute and Global Health Literacy Research at Health Literacy Media and a member of the Roundtable. After Dr. Pleasant's presentation, we'll hear from a panel which will be moderated by Cindy Brock. Ms. Brock is a Senior Health Policy Researcher at AHRQ, the Agency for Healthcare Research and Quality. She spearheads AHRQ's health literacy and cultural competence activities. She conducts and oversees research on health literacy and other topics, and is also a member of the Roundtable. So Andrew, we'll give it to you.
Thank you, Bernie.
And I'll take my water.
Alrighty. Hello. Hello. There you go.
Hey, Andrew.
Hey. So I don't know why I did this, but if you actually search for speaking right after lunch on Google, the number one consensus is don't do it. Number two is try to make a joke of it. So I'm evidence-based so far in my presentation. My task really is to set up the panel and just sort of introduce evaluation, and then you're going to hear much smarter people come. So apologies for that. But I also realized that on the webinar and on Twitter, for many people, this is not right after lunch. So I have a real live audience somewhere in the world, right, that's not doing carb overload. So basically, this is a very quick 20-minute overview in the broadest sense of the word of how I approach evaluating health literacy work in communities, and it also extends to health literacy in general. It's at a very high level because I will show you some logic models, but they're not the real logic models because they're so big in practice that they wouldn't fit on a PowerPoint slide unless it was like at a 3-point font, because there's so many learning objectives in the work that we do. But conceptually and theoretically, and this differs a little bit from other approaches that you know about or that we've heard about, I like this little mental equation, right? That ethics is an important part of what we do, especially in health literacy, but it should be true across all of healthcare and medicine. And often we don't talk about it a lot. So as this goes, ethical approach to programming and evaluation means that you need to look at effectiveness, you need to look at efficiency, you need to address equity, and you need to evaluate. Why? Because all of these are what we hope to achieve. I'd also hope that she delayed 5 minutes turning the green light on, but I got 30 seconds out of her, so that's good. Right, so everybody thinks they know what these words all mean because we use them a lot, probably too much. Right, ethics, a set of principles, a theory. So it is your belief system that really informs your ethics. Effectiveness, did the outcomes occur? Right, efficiency, what's the ratio of input to output? How many times have you ever heard that mentioned in relation to a health literacy program? Probably not a lot, but it is important. Equity, are you addressing equity in health literacy? If you're not addressing equity in health literacy, then exactly what are you addressing? I must ask, and then evaluate. So in a way, because I'm just geeky like this, and art and science are both equally important, I find there's some beauty in the logic of this, right? Because to be ethical, you have to be efficient, effective, and address equity. But to prove that you've done that, you have to evaluate. So essentially, evaluation is an ethical approach to everything that everybody in this room and in health literacy does. And me, I do find some beauty in that. So, because science, beauty, and art are not incommensurable. And in fact, they should probably get along a little bit more in the world, in my view. The goals of evaluation, there are many. This is not all-inclusive, but it's a pretty good sort of examples of the spectrum of possible goals. Everything, right, we talk about the first one a lot, you know, provide evidence of success or failure, but it also is there to justify funding, indicate areas you need to change and improve what you do, help share best practices, inform policy, wouldn't that be nice all the time? increase your own organization's understanding of what it is that you actually do and why, and what are the outcomes of that. Help inform systematic reviews in the future, right? So think if all of those evaluation approaches informed the choice of keyword searches. So then people said, this is exactly the field that we're looking at. Why? Because we looked at what the field did and reflected that, and then developed best steps and next steps. There are more. But overall, right? Everybody always likes, some of us like this cartoon. Right, usable is an important thing to think about. We talk about validity and reliability a lot, and then people produce data and they put it in journal articles and it gets peer reviewed, and for many people that's the metric of success. But it doesn't actually mean that they produce something that's usable and is gonna change the world, even a little bit. So you should actually keep your eye on the object, not your pre-planned goal, if it's not related. What evidence is not, because we talk about evidence a lot. I'll just jump to the last one, because evidence is not something that requires a Ph.D. to collect, even though people treat it that way a lot. Because you know the joke about what Ph.D. stands for? Good, then I won't say it a lot. I won't take that as a consensus, right? It's also not just a new idea that seems good or an opinion. And considering the news of the day, this is probably a pretty important list to keep in mind when people talk about what's true and false in the world. Another differentiation between myself and other people's approach to evaluation is that I firmly put it within the circle of research. There are people, look online, who will argue strenuously that evaluation research and research are two different animals. I couldn't disagree more. If evaluation does not live up to the definition of good research, then it's bad evaluation. And it's as simple as that. So actually, I really thought when I created the slide that no one would talk about this today, but I was wrong. Ariel brought it up, thank you very much. Right, we talk about all this data and what it's gonna do for us, and Katina joined in to that as well. Right, but it's not ours. All of this belongs to the people who were fortunate enough to be able to work with in a community. They own it. They let me use it, right? But it's their property, and if I don't give it back to them in a usable form, then I haven't lived up to my part of that social contract. And if you don't think that social contract exists, then you better rethink your relationship to a community, because it does. So enough said on that. What to evaluate, I'm not gonna go into great detail on this. This is a framework that indicates areas of possible evaluation, actually across all of research, but it is absolutely relative to health literacy. You can look that up. There are other frameworks that do the same thing. This is just the one that I was a co-author on, so therefore I owed it to my co-authors to put it up. So it's up. I actually like it. I use it. It's very effective. It helps you think through what you're going to include in your evaluation metrics. But in the interest of time, we will move on. So health literacy in communities. About half of this room has seen this slide at least 5 times. I've been showing it for about 15 years, and I'm still unconvinced that people actually understand the depth of where this simple slide can take you when it comes to designing health literacy interventions and thinking through health literacy. And it starts with, as the community panel earlier said, engaging people early and often in your work. How many people here can tell me with confidence that you know how to survive in the South Bronx on a $30,000 a year annual income with a family of 5? 2. I don't know. I have no idea. I'm not the expert in that. The people who do it every day, they're the experts in that. And you want to design a relevant and effective health literacy intervention and evaluation framework, you better involve them, because they're going to teach you more than you think. Just because they didn't spend as many years in college and university as some of us doesn't mean that they don't have a level of expertise that, while academics doesn't tend to prioritize that or highlight it or value it enough, that should change. And health literacy in particular should address that. If you do engage people, not patients, not participants, people with names, Bill and Ellen and Fred and Frederico and Emmanuel, you will naturally follow a path that means that you're talking to them about their entire life, right? You're not launching a program for people with type 2 diabetes. You're launching a program for people who happen to have type 2 diabetes and a whole bunch of other stuff going on in their life that's going to get in the way of your intervention if you only focus on their type 2 diabetes and don't talk to who they are in their entirety and don't include that entirety in your evaluation. Because in your evaluation, you're going to find people who the intervention didn't work for, and if you don't address their whole life, you're not going to know why. Right? You're either going to say, well, that intervention was poorly designed, we should have done it better, or these people just didn't show up because they didn't care enough. Neither of which are probably true. But if you don't collect the data to tell yourself what went wrong and what went right, by realizing that there are a lot of determinants of health, health literacy is just one of them. Michael, you're welcome. Then you won't reach this goal, right? Which is prevention. And prevention writ large also means taking care of people who already have a disease, right? It's not just about stopping something from happening. It's about reversing the course of a disease and preventing the worst outcomes that could possibly happen. This is a simple logic model that will take you to a very robust place in health literacy if you let it. But all of that wasn't really about evaluation, but yet it is, right? Because if you engage people early and often, what does that mean? You are conducting formative research and evaluation in a community. You're not taking a program off the shelf and launching it in a community that you don't know and that they don't know you and that you haven't modified and tailored to that community based on the reality of that community. Right? Not doing that is the easiest recipe for disaster that I can think of in this field. It also means, right, that you're taking a participatory approach. And none of these, by the way, are binary. It's all on a gradient. There is no yes, no. It's how much, how often, how, and when, and how many people. So you're not scoring yourself on a 0-1 here. You're thinking of, because life is complex. It's not just like little boxes like we got taught in master's degrees, right? It's complex and rich and busy. If you include your whole lives in your evaluation, you're thinking about who do I ask questions of, when, where, right? And who asks the questions? Because in many of the communities I work in, the last thing you want is a tall white guy with a pen and a piece of paper asking people questions. Right? That means trouble to a lot of people in this world. And that's true for a lot of us in this room. And if you don't embrace that reality and figure out who's the right person to be asking the questions, then you're going to miss the boat because people are going to tell the tall white guy what they always tell the tall white guy. Right? And there's a good reason for that. And if you think about prevention, in evaluation terms, that reinforces the absolute need to always include an objective health indicator in your evaluation. Satisfaction's lovely. Understanding's lovely. Self-efficacy is fabulous. I do all of those. But it's nothing like being able to say, your blood pressure dropped X%. Your hemoglobin level dropped. Your BMI lowered. That's what we're all trying to create is healthier people, but we're not trying to create that actually. I misspoke. We're trying to help them create that in their life. That is a very big theoretical difference there. When to evaluate? Not then, right? Not after you've already decided what you're going to do, and not after you've launched it. Yes, you do post. Yes, you do plus 1 year. But if you haven't started your evaluation before you've finalized your intervention, you've made a mistake. Sorry to be so blunt about it, but that's just the truth. In a classic sense, in the academic words, right, when to evaluate, formative before you've started anything, to inform, baseline before you've actually launched the initiative, process to make sure that the process is or is not going the way that you planned, and just because it is not, as we've already heard, doesn't mean it's wrong. It might mean that you learned, right? But you need to document that too. Outcomes, immediate post, long-term post, and then sustainability, which most people leave off because it costs too much. But it is important. So what's the best practice? All of the above, right? There is one best practice, it's do it all. So quick example, like I said, 20 minutes, sorry, 20 and a half, because thank you for the 30 seconds. Theater for Health, Healthy Community, Healthy Table, Life Enhancement Program. These are all different interventions I've launched in communities over the last decade. The LEP, At minimum, it's 40 hours of contact time. And I'm going to stress this contact time for a point that we'll get to, right? I'm not going to tell you a lot about the program, but it's an integrative health program, and it basically covers all of the health determinants in a person's life over 40 hours in a variety of different ways. Modalities, one-on-one sessions, grocery store tours, group sessions, hands-on, practical stuff. We always offer it in partnership with a local healthcare provider organization who's already known in the community. Their staff gives it, we train them. This is a semi-superficial logic model because, like I said, it's 40 hours, so there's at least 120 learning objectives in the whole program. So if I listed them, we'd be here all day. We don't have time. So this is the collapsed version of the logic model, right? There's what happens before the program, the process of the program in 2 streams. Improve health literacy leads to behavior change. You can argue with me about whether health literacy is a behavior change model all day long, but for this talk, it is. So let's just go with that, right? That will improve individual health status. The aggregate of individual health will improve public health, and the cycle repeats itself over and over. Health literacy outcomes, just to focus in terms of evaluation, there's 2 ways to do this. One is you take your definition of health literacy. I use the Calgary Charter: find, understand, evaluate, communicate, use. Communicate is incredibly important at the community level because that turns into diffusion of innovations, right? How many people have you shared what you learned with? It's a pretty simple question. Find, we know the people who find our programs have accomplished that, right? We bring it to them, we launch it, we advertise it, they come, they have found information. Understanding, easy, we do always. Some just straight up knowledge questions, right? What is this? There's a lot of variety of ways to do that. Multiple choice, open-ended, et cetera, et cetera. See if people get it right, if they get it wrong. If they get it wrong, then you know you need to reinforce your curriculum on those points. What do we see? Around the 20% increase in health knowledge because of this. Evaluate, the next step in the model. Self-efficacy is a lovely surrogate for the evaluate phrase, right? Because if you've gained confidence in it, in fact, what you've done is evaluate yourself and your ability to perform in light of that area of knowledge, whatever it happens to be, nutrition related, exercise related, and you're like, yeah, I can do that, I get it, right? I know how I'm gonna do this. I'm confident in my ability. Depending on the context, we see between 9 to 20% increase. Communicate in this program, people share it with over 15 people on average. So you move a group of 200 people through, each of them talks to 15 people. In some communities, that's a significant number of people. What we haven't done yet is go to the next layer and find those 15 people and ask them who they shared it with, but wouldn't that be fabulous? But then again, funders, that'll cost some money. But wouldn't it be great to know, right? And then finally, use, that's behavior change. We see statistically significant changes in blood indicators, depression, stress, civic engagement, and that list could go on and on and on and on from this program. It's one of the most effective health literacy programs I've ever seen, but maybe I'm biased. So we shall see. The other way to do it is simply use this health literacy scale that we've developed over the last 8 years. 5 simple Likert report statements, and you see the differences between 7 and 14% on a self-report scale. But if you go back, 7 to 14%, 9 to 12%. People are self-reporting fairly accurately when you compare their self-reports to, in fact, a more quote-unquote objective indicator of the steps of health literacy. So you can do it both ways. It's entirely up to you, right? What is your surrogate? What is your marker for whatever definition of health literacy you use, or can you just do a self-report? In our experience, they seem to be fairly both effective. Theater for Health, which is a community program that uses theater to change behaviors around health issues, any health issue. The first launch was in Peru. We focused on household hygiene. The process, much like you heard this morning, identify local partners, do the formative research, learn about the community. We did a workshop with the actors and the scientists because we had to teach the actors the science and the scientists the art so that they could all get along because they're all on stage together. Do the baseline collection in the community. We did 12 episodes over 11 weeks in this iteration of this program. We collected process data after each episode. And that doesn't mean we spoke to the entire audience. It means we randomly selected 20 people and got a cross-section and learned what they thought about the performance and what they expected to happen next week and if they were going to start to change their lives in a qualitative fashion. After the performances ended, we did the post-data collection in the community. One of the critical differences between this and the Life Enhancement Program is that this evaluation was a random sample of the community. So we had no guarantee that the people in the evaluation were actually going to go to the performances. And in fact, some of them didn't. Whereas the Life Enhancement Program, we do 20 people at a time. In each session, they're all evaluated, but over time, that 20 adds up to hundreds and hundreds of people in a community, so it becomes more and more reflective as we move forward. So back to Theater for Health. Here's, again, the abbreviated logic model here. Right, the intervention was the arts, the theater, all informed by science and evidence. We did the formative research baseline process outcome to see if we could improve individual and public health. You do need to have an understanding like this of your intervention before you evaluate it. But key point, this is not at the level of detail that it needs to actually be. Right, so don't just mimic this. It needs to be bigger, broader, and more robust. The outcomes we found, 97.6% of the people we surveyed randomly in the community actually did go to the performances. Lovely little side point, 7.3% said they attended, but they didn't pay attention. Right? But what does that tell you? That tells you that they're telling you the truth. Right? So in your evaluation, it's nice to have some checkpoints like this, because the tendency to sort of tell an interviewer what they want is strong in human relationships. So figure out a way to validate internally your answers. Ask the same thing in two different ways and see if the responses come out to be relatively same. If they're significantly different, then something's going on. Right? It might be that people lied. It might be that they didn't understand. It might be that your interviewer was poorly trained. There's a whole bunch of causes of that, but you need to check in on that. Knowledge increased 65%. And by the way, that is the community. And we were addressing household hygiene. So you get a notion of what's going on in the community. I told you I was going to see red and stop real quickly. So we don't need to see that. You get the rhythm of what's going on here. Right? And this is the newest one, Healthy Table, only looks at nutrition. We haven't got all the data in yet, but it's the least intervention, right? 17 and a half hours. This is the smallest total intervention, and we're still seeing that 2 people cut their hypertension meds, 1 in half, one by 25%, because they both reduce their solid intake. The point of all this is, right, think of the dose response part of this and equity. The most expensive and the biggest contact time is the Life Enhancement Program, and just one of many indicators, 41% decrease, right, in the direction that you would want it to go. Whereas Healthy Community at 17.5 hour, 11% decrease. So the message to funders here is clear. Health literacy interventions can be expensive, but if it's evaluated well, it's worth it. Because it costs, in 1 year, you break even on the strongest program, the cost of the program against the cost of improving people's health. And that's what evaluation can and should actually teach us about what we do. It's not just outcomes or satisfaction. It's how do we change the health system and inform policy. And I'm done.